Good afternoon, everybody. Thank you for being here. I'm really excited to be talking to you today about the intersection between trauma and substance use and the impact of that lens on stigma and on treatment, as well as how trauma and substance use are passed down intergenerationally. Okay, that's important. Okay. So I'm assuming that we've all seen this, right? Many of us have seen this over and over and over again, but a really important framing, so I'll just move through it quickly. So back in the mid-1990s, the CDC and Kaiser Permanente did a study called the ACEs study in Midwestern America, primarily going through folks' health insurances to take a look at how does what happens to us in the first 18 years of life impact health across multiple domains in adulthood. And so the study found that there are 10 adverse childhood experiences that are shown to really have an impact. So things like having physical, sexual, or emotional abuse, having a parent with a mental health disorder, a parent with an addiction, seeing your parent being incarcerated, etc. And this was a really important study for people in my profession who have said, what happens to when you are little is really, really important when you grow up, not just in terms of mental health, but really looking at that mind-body connection. So we saw from that study strong links between those 10 early experiences and really the biggies in terms of public health. Stroke, cancer, COPD in terms of physical health, to name a few, as well as incarceration, missed time at work, broken bones, so really running the gamut in terms of effects from what happens in childhood to what happens in adulthood. Now, that study was really important and gave us a really important framework, but it was flawed in some ways. So it talked about how it was conducted through health insurance and mainly on white, well-resourced families. So in 2019, the study was replicated in an urban community in Philadelphia to really take a look at, well, what does this look like in a more under-resourced and under-resourced community? And we found, not surprisingly, that there were more ACEs overall, and that we also saw high numbers of ACEs in what we call the community ACEs. So things like experiencing poverty, experiencing racism, living in an unsafe community, having food scarcity, that these things are also really, really important to be looked at in terms of adverse experiences. Okay, so where we kick it into the conversation around opioid use and substance use is looking at the impact on early childhood experiences and substance use rates in adulthood. So my eyes are bad, I can't see back there. I'm going to turn around here. In general, the higher the ACE score, the higher the correlation with alcohol use and substance use in adulthood. And we saw, I feel like these numbers are just absolutely mind-blowing, right? With 4 or more ACEs, a 500% increase for adult alcohol use disorder. Men with 6 or more ACEs, a 4,600% increase in IV drug use. And that about 78% of drug use in women can be attributed to ACEs. So where I work at the Center for Great Expectations, we have a full continuum of care that focuses on mental health and substance use disorder treatment for pregnant persons and their children. So we treat the system together. And I will tell you that the average number of ACEs for someone who comes into our continuum is 6.3. Many, many, many of our moms have all 10 ACEs. So starting to take a look at the connection between trauma and addiction, we see that one of the hallmarks of a substance use disorder, particularly through the lens of when we look at early experiences, creating that vulnerability to substance use, is that there is a problem, there's a difficulty with self-regulation. We're going to go into a lot of the mechanics of that going forward, but we can really start to see substance use as something that makes a lot of sense when someone has had high levels of trauma during childhood. And we talk about the idea of complex trauma as being distinct from PTSD. So without going into all of the different criteria, we can think about PTSD as being related to an event or a series of events that happened or were perceived as being life-threatening. And complex trauma is more around when you have multiple events that happen early in childhood, often within the context of a relation that the person has a biological expectancy to be caretaking. So not only bad things that happen, but also the absence of the good. So the absence of nurturing, co-regulating relationships, the absence of having, enough money to know where dinner was come from, living in constant stress. We think about the ACE of having a parent who's incarcerated. Yes, the moment that the child may have witnessed the incarceration would be traumatic, and that would be important. But then we think about what is it like to live in a home where someone has been incarcerated, now you have less income, and the other parent may miss them, or they may be angry, or the neighbors aren't talking to you. How does it change sort of the water that we swim in when young people are in environments where they're experiencing ACEs? So long story short, a child who's exposed to these events is often left without a parent who is regulated and can co-regulate with them. And so we see substances as coming in, and it makes a lot of sense that substances will regulate our nervous system, right? Until they don't, or they cause other problems. But we often say to the moms who come in, like, thank you, substances, for keeping you alive, to the point that you could get here, that you didn't die by suicide, that you were able to use something to cope, and now you're here because it doesn't work for you anymore. And the second piece being, when we look at adverse experiences that happen within the context of caregiving relationships, because think about the ACEs again, right? It's childhood abuse, neglect, sexual abuse, having a parent with a mental health disorder. These are things that happen within relationships, and the child has difficulty trusting individuals, realizing that relationships can be healthy and caretaking, so this person goes into the world with difficulty managing their emotional state and their nervous system, and also difficulty making connections. So this is a quote by Bessel van der Kolk. If you're interested in trauma, I would highly recommend looking him up on YouTube or reading any of his books. Really just looking at substance use as an adaptation to trauma. And I think all of the speakers today in one way or another have really touched on this idea of, and I think about like some of my better Facebook comment fights where someone says like, why would we invest resources on a drug addict? Why would we give housing to someone with an addiction when we could give it to someone who's trying really hard? But we can really start to think about when there's a 4,600% increase in substance use at 4 or more ACEs, are we even talking about choice at this point? So what I'm going to invite us to do is take this information and really shift our own lens, or really gather some language and some ways of thinking that you can take back to your communities, your workplaces, the people you work with, and help them to shift their lens. So the first would be this idea of shifting from the idea of what's wrong with you, that you have a substance use disorder. And in my line of work, I can't think of anyone who's more stigmatized than a pregnant person who is in addiction. How could you? And I sit across from moms who sit there and they go, how could I? It was stronger than me. It was stronger than my love for my child. So really thinking about a change from what's wrong with you, this moral deficiency, this character defect lens, to what happened to you. We talk about getting to the root of the problem. What are the things that happened to you that dysregulated your nervous system that you are now using substances for as a coping mechanism? We can really start to think of addictive behaviors as becoming survival strategies. At CGE, we talk about the sword and the shield, right? When there's a mom who we kind of hold a limit on something and her survival kicks in, oh my gosh, if I don't get this thing, what am I going to do? That we can, instead of saying, no, you're not going to graduate until you get your emotion regulation down pat, to like, hey, look at me, I got it, let's breathe together. You didn't learn how to do this from your parent, I'm going to sit with you, what's going on right now? Let's breathe through it. What are you feeling in your body? Let's kind of learn how you can change the way that your body feels so you can learn to respond instead of react. So we're thinking about a paradigm shift in a couple of different ways, from a lens of punishment to a lens of safety. Right? You can't punish somebody out of the things that they have adapted to in order to survive in this world. How do we create a safe space for this person where they can regulate without substances? Moving from distrust to trust. Whether we're the EMT worker or we're in a hospital or we're a home visitor, coming in and intentionally saying, how can I make myself trustworthy to this person who's been violated time and time again by the people who are meant to take care of them? Moving from this idea of confrontation to collaboration. I always hear language like, oh, the person admitted that they used substances. And it's like, well, if they are doing it because they have zero ability to regulate their nervous system, are they admitting that or are they sharing that? Are they disclosing that? Being really careful about our language. Thinking about an authoritative lens in terms of treatment or policing or different ways that we're interacting with folks to a place of choice and empowerment and harm reduction. Really, really important here. I think it was mentioned earlier where there's harm reduction and there's treatment, but there's also treatment that embraces harm reduction. And how can we really bring those two things together? And then really moving away from this idea of compliance, of being compliant with treatment, that as the home visitor, as the public health person, as the nurse, as the educator, that I don't know what's right, and I'm not expecting you to do what I say, but really collaborating and creating a transformation that's based on that individual's needs. So thinking about our language. So these are some of the words that are kind of popular in our culture to describe people with addiction. Are you clean? Is your urine drug screen clean or is it dirty? We can shift that to, is it positive or is it negative? Did it come up for substances or did it come up that you haven't used substances? Sober, in recovery. In denial, early in the change process. Relapse versus recurrence or using again. So really just starting to think about in the moment when we're with someone, we've come so far in terms of being aware of what people's pronouns are and asking them how they want to be addressed. Let's offer that same level of seeing a person as a full person in who they are, of respect to people with addiction. Okay, so I think this is where it gets really, really cool. So we're going to start to talk about how trauma and substance use are passed down between generations. And interestingly, the child of a person with substance use, with many adverse childhood experiences, has an increased risk for poor physical, behavioral, and cognitive outcomes across the board in many, many domains. So we're going to talk about many of the different ways that that happens. Not all of them, but to give you kind of an overview of how complex that is. And this study was done in Japan in 2010, and they had mom lying down with an ultrasound on her belly, watching a movie on a screen and listening to headphones. So the gestating prenate was about 6 months old, could not hear anything through the room. Mom was listening on headphones. And mom would watch a neutral clip of a movie, and then either a clip from The Sound of Music, like the twirling in the Alps, which was intended, studies have shown that that movie induces high levels of happiness, and then a neutral clip. In another group, mom watched a neutral clip, and then a scene from The Champ, where this boy is crying as his father dies after getting like a bad KO in a boxing match or something like that, and then another neutral clip. And what they found was that when mom watched the Sound of Music clip, they looked at fetal arm and leg movements. The arm and leg movements went up while she watched the happiness clip and then went down to about baseline. But when she watched The Champ, fetal arm and leg movements decreased and then never came back to baseline. So starting to think about the implications and the theories that come from this, that perhaps the infant is having a direct experience of mom's emotional state. And what if mom is in poverty, in an unsafe neighborhood, in a DV relationship, has food scarcity, is working 3 jobs? that cortisol is always going, what is that gestating prenate experiencing? Okay, so this slide is overwhelming. The basic premise here is that the fight, flight, or freeze response, right? We've all heard of this. How does that happen? Basically, there's an alarm system in the brain. The amygdala scans the environment for danger. When danger is detected, it activates the fight, flight, or freeze response through this cascade of different hormones, which ends up basically with the secretion of cortisol into the bloodstream. Now, a couple things. So someone who has a history of ACEs, who has a history of complex trauma, is going to have a more sensitive HPA axis. It makes sense that if you grew up in an unsafe neighborhood, you want a quick response to danger. That sometimes you think about somebody who has like a startle response. Oh, nothing was really there, right? But you have that startle response that's going to keep you safe from perceived danger. So that being more heightened and sensitive in individuals with more ACEs. So typically during pregnancy, the placenta secretes a hormone which will change cortisol into its inactive form, cortisone. But when a pregnant person is in an unsafe environment, when their HPA axis is going and going and going, that hormone is not released, and cortisol does pass through the placenta, and the gestating prenate is exposed to cortisol, which in high levels is toxic. So the question becomes, why? Why would that happen? And what we postulate is that the prenate, through direct experience of maternal emotions, through exposure to cortisol, is developing a brain that will help them to survive in the environment that they're being born into. So prenates that are gestating inside of very stressed mothers are being born with larger, more reactive amygdalae, I think is the plural, amygdalas. Again, that part of the brain that scans the environment for danger and activates the fight, flight, or freeze, and smaller cerebral cortices, the part of the brain that governs language and prioritization, planning, impulse control, emotion regulation. Because that child needs to have a sensitive response system if they're being born into an unsafe environment. So really looking at how the relationship between the parent and the child begins during gestation. That the prenate is having an experience of the mother, is having an experience of the mother's environment, and there is a relationship that's happening at that point. The mother is really the child's environment during gestation, and we see that there are some very real public health concerns that come out of this, such as increases in pregnancy and delivery complications, preterm birth, and low birth rate. And particularly, DV stands out as an experience for the mother during pregnancy that affects the child throughout their lifetime. So we see emotional difficulties, aggressive behavior, violent crimes, and increased suicide in children whose mothers experienced interpersonal violence or domestic violence while the child was gestating. So we've been talking about the amygdala, the part of the brain that scans for danger. When we think about the brain, the job of the brain, more than anything else, is really to keep the body alive. And we talk so often about how the human brain is so marvelous because we can do art and we can take another person's perspective and we can have empathy and all of these things that we say make us uniquely human. And yet at the end of the day, those sorts of higher level things will be deprioritized if the brain needs to put its energy into keeping the body of the person who houses it alive. And when there are traumas that happen during childhood, we actually see an influence of the size of the amygdala. So when we look at the levels of maternal cortisol during pregnancy, we see a 6.4% increase in the size of the right amygdala, which is like really getting down to basics, but the part of the amygdala that really governs emotionality in girls. And interestingly, I don't want to go on a tangent, but there's a lot of interesting research around females tending to be diagnosed with higher rates of mood disorders than males. I think there's a lot of things that go into that. It certainly isn't just this, but just very interesting. So starting to think about, we talked about how the infant is experiencing the mother during gestation. And now we're going to shift a little bit to those very, very early interactions between mother and child during the postpartum period and then going into early childhood. So we need to take a look at maternal mental health. We have some pretty serious issues with mental health in our country. So postpartum depression is reported more than twice the time, at twice the rate for Black birthing people compared to the overall population. So 38% of Black birthing people are reporting postpartum depression. That's almost half compared to 13 to 19% overall, which isn't great either. Postpartum anxiety at about 17%. Postpartum PTSD, so looking at PTSD symptoms that happen directly after childbirth and after a negative or a traumatic childbirth experience. So 9% of birthing people are reporting postpartum PTSD with full symptoms, and that's a hefty diagnosis in terms of criteria to meet, and 18% being symptomatic in some way or another. 0.5% reporting postpartum psychosis. So the interesting thing, just to give an example about how this kind of all rolls out, is if we think about postpartum PTSD, one of the symptoms of PTSD is avoidance of the stimulus of the trauma. If we had a traumatic birth experience and the child is perceived by the parent to have been, you think about the child getting stuck in the birth canal and there's a vacuum extraction or an emergency C-section, that child can at times actually become associated with the trigger of that traumatic experience, so the mother avoiding the baby. So we talked about how the amygdala scans for danger, and the cerebral cortex is involved with executive function and higher functioning. And there's a part of the brain in the cerebral cortex that's called the prefrontal cortex. It's right up here. When we go, it's interesting because we're like, oh, I don't know what to do. We're literally like kind of palming that part of our brain. It's the last part of the brain to fully develop. It develops around age 25. My brilliant clinician who was hired a few weeks ago was like, I waited to 25 to get married because I know that that's when my prefrontal cortex is fully developed. Like, yes. But wait till you're 40, it's even better. So the part of our brain that allows us to regulate our emotional state is the prefrontal cortex, last part of the brain to fully develop. The only way that this part of the brain develops is by being in interactions with regulated caregivers. So then we think back to this thing about substance use as being an issue of regulation. The moms who come into the Center for Great Expectations with 6, 7, 8, 9, or 10 ACEs, when they talk about their relationships with their parents were using substances and were dysregulated. They were living in poverty. They had DV in the home, and so did their parents as far back as we can go. So we look at a depressed mother, we look at an anxious mother, a mother with postpartum PTSD, a mother who is dysregulated for whatever reason, and we can start to understand the way that that will impact her interactions with her infant and how important that is for that infant's prefrontal cortex to begin to develop its ability to regulate itself. So when I'm standing up here in the beginning of a lecture, I always notice for the first minute, like my voice is really shaky and I'm like looking for the friendly face in the crowd, and if I see somebody look at their watch, I think I'm actually going to slip around here a little bit. I'm like, oh my gosh, that's because I'm a really horrible presenter and I'm not speaking clearly in X, Y, and Z. So when we are dysregulated, we lose our ability to tune into the faces of the people in our environment and accurately interpret what they are saying on their face. When I'm dysregulated and you look at your watch, I'm like, oh, I was thinking this. Not maybe they're waiting for their child to call, or maybe they need to take medication, right? We slip out of our amygdala is firing. There's danger, I'm not doing a good job. Part of my brain that involves logic that might say, well, maybe they have an appointment, goes offline, and it becomes all about me. So this kind of shows us how this happens. The arrow on the left talks about the increase in stress, and as stress goes up, we move away from this green zone, which is a very engaged zone of being. This is when you've finished working out, you've done your breathing exercises, you've done your meditation, you're well fed, you're hydrated, you're hanging out with someone you love and trust, you are in the green zone. You can be in the present moment, you're feeling grounded, you can access joy and curiosity, and you're most likely to accurately tune into someone and be curious about what they're thinking and say, oh, I wonder if they have an appointment coming up, or I wonder if I need to speed up my slide. We need to be in the green zone in order to be socially engaged. When we move up into a fight or flight response, the sympathetic nervous system is activated. We lose our ability to tune into others and co-regulate or make accurate meanings of what they're saying non-verbally. And then if we can neither fight nor flee, arousal continues to increase, we go into a freeze response, sort of a numbing, a dissociative response, a shutting down. Think about that possum who plays dead. So the reason that this is important is that if our moms are in the red zone or the blue zone, if they're in fight or flight, if they have addiction or mental health issues, if they have difficulties with regulating, or they're in that freeze where they're dissociative, or they're not able to engage, they're feeling numb, they're not showing emotion on their face, and this dysregulated parent is interacting with an infant, the infant is not having that part of their brain built in order to regulate their own emotions. So we talked about the opposite of addiction being connection, one of my very, very favorite quotes, and we can start to think about, as we talk about moving the needle on opioid use, as we talk about harm reduction, as we talk about shifting our lens to harm reduction, we really need to bring in the power of human relationships, parent-child relationships being perhaps the most bang for your buck in terms of where to intervene, but other caretakers, home visitors, resource families, teachers, etc., providing young people with high-quality, regulated interactions so we can build that part of their brain to be able to regulate themselves on their own and not need to turn to high-risk behaviors, with substance use really only being the cell body, and then we have the axon, and what happens is nerves will communicate with each other by sending electrical signals over kind of the gap between nerve cells. We're born with all the nerve cells all the neurons, all the brain cells that we'll ever have, but the connections that happen between them happen most prolifically during the first 3 years of life. So this is a child's brain at birth. We have the neurons, there aren't very many connections between them. But the brain develops in response to its environment. So if this child is in an environment with regulated caregivers who have enough resources to be able to devote time for face-to-face interaction, first of all, to be regulated enough that they can be patient when the child is crying at 2 a.m., or when they're 2 and the child shouts no and throws a shoe, that the parent can be regulated enough to look at the child's face and think, 2 years old, becoming independent, want to do it by themselves. They didn't really mean to disrespect me, it just felt disrespectful. I'm going to stay regulated and say, okay, honey, I understand that you want to do it by yourself, but it's time to go to daycare, right? This is what children need in order to develop brains that can regulate their bodies. So at birth, not many neural connections. By age 7, look how densely populated those connections are. More brain cells haven't been created, but they're linking to each other. They're talking to each other, and they're doing that based on what the environment is eliciting. Are these connections being built around survival behaviors? Be a good girl. don't get in trouble, shrink. When the parent with the substance use disorder comes home, show the good grade that you got at school and be cute and adorable. Or on the other hand, be angry, be outraged, throw something at that parent. What kinds of survival skills are being connected within that child's brain if they're in a survival environment, as compared to a child who has loving interactions or has music in the home and is hearing language all day long and is being able to manipulate objects with play, and the home is safe enough that they can explore the environment. The brain develops in response to its environment. So what do we do about that? Going to hopefully give you some ideas for things that you might be able to integrate into the marvelous work that you're already doing. And one of them would be to start to think about, when we're working with parents with substance use disorders who have children, yes, parenting skills are important, and that is something that we can provide to folks, but really the issue isn't so much not knowing what to do, but having the capacity to regulate their emotions as a parent. If I've grown up in a home with a lot of ACEs, I can't regulate my own emotions, I was using substances to regulate my emotions, and now I'm in recovery, I don't have any tools to regulate myself, and now I'm interacting with my child. So we want to focus on building capacity for emotion regulation in the adult, not just coming in with a sheet of like, this is how you do a timeout, right? Does this is how to do a timeout matter if you're so dysregulated that you'll be screaming at the child? Thinking about capacity building and not just parenting skills per se. We also really want to shift away from this idea of the parent and the child being separate and really look at them as an interactive system and start to think about, how is the child dysregulating the parent and how is the parent dysregulating the child, and how can we flip that script that we can start to have the parent become a little bit more online and regulated, and then they can regulate the child a little bit, and then they can start to see, look, I can do this, I'm doing something good for my kid, and really shift that pattern to one of mutual co-regulation. We think so often about, this comes from my days as a doula, we talk so much about like, when baby comes home, everybody wants to hold the baby, but who holds the mother? As public health workers, what do we have in place to really honor the safety needs, the needs for access to social determinants of health, the need for safety in the environment of a pregnant mother who's gestating the brain of this baby that's developing in response to its environment, as well as during these first 3 years of life. We see so many studies around the effect of parental stress, thank you, that went really, really quick. The effect of parental stress on parenting capacity. When parents are stressed out, like think about if you have a parent or you have a niece or a nephew, when you're stressed out and your child's acting up, how effective are you? Right? So really thinking about those systems and how we can change them to support stress regulation. Because the mother's face is the child's first mirror. We really look at children developing a sense of who they are in the world by the parental response. When that child reaches out, is that parent in a place where they can say, oh, yes, like, touch my face? Or are they saying, like, I gotta get to work right now or I'm gonna be late, and they push the child away? So we're gonna scoot because I took too long. But some things that we can do. Number one, when we are interacting with a family, is for us to recognize what we are bringing into the room and what is our level of regulation. If we're working with a substance-using parent or a parent in recovery, we become the regulating interaction. So it's really about us staying regulated, us staying non-stigmatized, us staying in the moment where we can co-regulate with the parent. And then the parent has that experience of being co-regulated with and then can bring that into their interaction with the child. We want to be screening for postpartum mood and anxiety disorders across the board. We're doing it a little bit, we're not doing it enough. We also do it like before mom leaves the hospital when she's usually still somewhat influenced by the hormones at birth, but what does that look like 1 week, 2 weeks, 6 weeks later? Postpartum mood disorders are also diagnosable within the first full year of life, so we want to be screening for that full first year. We can also, when we're interacting with parents and children, as much as we can, try to treat the parent as the expert in their child. If we're coming in, someone's coming into our office, etc., and we know better and we kind of model what to do, what is that doing to that parent's self-efficacy? Find something that that parent is doing well. Wow, look how your child scooted closer to you. You feel so safe to them. You're their safe place. Building efficacy in the parent. And just closing with this quote that I believe to be so true and such a powerful place for us to focus our interactions. So with that, we're just about at time.